Good morning, everyone, and welcome. Thank you for joining us today to our fourth annual Emanate Health Conference in our first virtual program on COVID-19 in the San Gabriel Valley, which truly reflects the era in which we live in. I'm Diane Martin, Chief Marketing and Communications Officer for Emanate Health. It's my pleasure to formally welcome you to this year's event. Although we cannot be together today or in person this year, we hope you will enjoy this year's program to give you a greater understanding of COVID-19 and what to do to keep safe during the pandemic. Geography, resources, and accurate information has become more important than ever. Before we get started, I'd like to take a moment to thank all of our Emanate Health frontline healthcare workers. They have done an incredible job since the start of the pandemic to keep our communities safe and well and informed as COVID-19 spread throughout the country and the region. I'd also like to thank our sponsors who are helping us educate the community. A very special thank you to Northwest College, First Med Ambulance, Self-Care Catalyst, and Emergency Ambulance Services for helping us live our mission by keeping our communities informed. We do want to encourage everyone to ask the doctor and ask the questions that you have in mind in the chat box, which is going live. So please submit those questions and also submit them for our speakers. If we do have a moment to answer all of them today, we will. But if we cannot, we will post the event. So now it's my pleasure to introduce our moderator and Chief Medical Officer, Dr. Gurjeet Kalkat. We have been fortunate to have him lead the clinical operations for Emanate Health. He has been a critical leader in coordinating the most current medical care for our community and provide guidance to tackle the ongoing pandemic. Dr. Kalkat is a pulmonologist and critical care physician. Together, in the last couple of years, we've been able to bring content that is relevant and important to our community, from medical innovations to share advances in healthcare in the San Gabriel Valley, to aging well topics to care for our seniors to increase chances for a better, healthier life, and now on COVID-19 to help keep our community safe during the pandemic. It is my pleasure to welcome my esteemed colleague and friend, Dr. Kalkat. Thank you.
Thanks, Dan. Good morning. Welcome to this virtual conference on a great Saturday morning out here in California. We have these conferences every year, and through these conferences, we are living up to Emanate's vision of being an integral partner in elevating the health of our communities. So this year, we had other plans, but COVID, of course, changed everybody's plans on this earth. So we had to pivot to present what's happening around COVID so that we can work with COVID, because this is not going away for a long, long time. Things are a little better in our area as far as COVID is concerned. Our numbers are, quote, down, but nationally, things are getting very much worse. Yesterday, we hit a new high of 82,000 new COVID cases in the USA. That's the highest it's ever been. We've had more than 220,000 deaths. Locally, we've lost 7,000 folks in LA County. In our area at Emanate, we've lost 185 patients, unfortunately. Today, we have 39 patients admitted with serious COVID disease in our 3 facilities. Even though things are looking better locally, we have to be prepared. We have to know everything about COVID, because COVID is our near future. Keeping that in mind, we're going to have 3 speakers to talk everything about COVID. Our 3 slate of speakers will help you plan for the future. You're going to know how this started, how to manage or treat this disease, and how to prepare for the future. Our first speaker is going to be Dr. Geraghty. It's my great pleasure to introduce Dr. Geraghty. Dr. Geraghty is actually now known worldwide. A little background about her: she was trained at UC Davis as an internist, and then she went on to study about medical informatics, and she pivoted to join a company named Esri, which actually started off as a land-based data firm, but then pivoted to geographic information systems. And they've used this data to help us track COVID. When we look for COVID data anywhere in this world, we look up to Johns Hopkins, and Johns Hopkins gets all this data from COVID, from Esri, and Dr. Geraghty knows everything about the COVID data. So her talk, GIST, Innovations in the Future, that is Geographic Information Technology, Innovation and Future, is going to enlighten us about how COVID started and where to go from there. Dr. Geraghty, welcome.
Thank you so much, Dr. Calcat. I really appreciate it. And it's wonderful to have this opportunity to share about what's going on with COVID, innovation, and the future. And I'm going to share this from really the point of view that I know and understand the best, which is, of course, geospatial technology. So the first question you may be asking yourselves is, what is this geospatial technology? Well, we call it Geographic Information Systems, or GIS, and it's a computerized technology that's based on geography. And geography, of course, is the science of our world. So just think about that for a moment. Geography provides us with all of this rich content about our world. There's the biological content, ecological content, sociological content, just all of the ologies, right? And it can be put into context using a common reference system, which is geographic location. And the geographic lens helps us to more easily see and digest complexity and relationships and patterns of different sorts. And this is probably part of why people tend to really love maps. And honestly, the science brings it all together in the most remarkable way to help us understand and intelligently respond. And that really paved the way for a lot of innovation. But you know, some people don't believe that you can or should innovate in the midst of a crisis. Oftentimes people are so busy responding to the crisis that they feel they just don't have the time to improve their systems. And initially, granted, that may make a lot of sense to you, but actually, according to the Harvard Business Review, a crisis creates a number of conditions that work together to support rapid and impactful change. Here's why. One of the first things that happens is that an organization will unite around a shared purpose, which enables a sense of courage, actually, to take action that might be unthinkable during more calm times. A crisis also tends to magnify and clarify where vulnerabilities and problem areas exist, and this really forces us to confront our systems that may not be working well, and we really start to see things a bit differently, which gives us ideas for improvement. The other thing that happens is that there's a lot of incentive to get things done quickly, which can help us to overcome bureaucratic red tape. And as you well know, a crisis can create a great deal of energy to move. And when that energy is focused on a common goal, a lot of innovation can get done. And so I want to show you some of the evidence of that innovation that we saw early on in the crisis for Esri users. And so I'm going to ask Steve to please play a short video clip for you. All right. Well, I really love that video. It kind of makes me feel like I'm a part of something bigger. Over the next several minutes, I'm going to show you that there's an awful lot to be gained from using GIS for health. Now, for many years, health organizations have amassed impressive stores of data. With GIS, however, we can go beyond collecting the dots, the data, right? We can use place and location analytics to then connect those dots to create new insights, new information, and informed action. So how did it all start with COVID-19 and the geographic innovation that really helped to connect those dots? Well, if I were to summarize it, I would say that it started with a bang and it moved very fast. Starting here really with the world famous and in fact now iconic Johns Hopkins University dashboard. Now this dashboard built with GIS technology is the most viral map-based application in history, and it really woke up the world to the evolving outbreak. Now they collected the dots and they continue to do that to this day. One thing that I think is so important about this dashboard is that from the beginning, the Johns Hopkins University team made sharing those dots their first priority, and this enabled all kinds of organizations to do their connecting the dots through visualizations and analysis and planning scenarios that enhanced decision-making for their individual local COVID-19 response. Now, the dashboard had tremendous uptake, and it quickly became the backdrop in operations centers around the world, from the US Health and Human Services Secretary's Operations Center to emergency meetings that were happening in Germany, coronavirus briefings in Italy. We saw it as a backdrop in Ireland, among so many others. And the influence of the dashboard really broadened when respected journalists started to write about it. And that coverage was extensive, but some notable examples included the New York Times, BBC World News, and actually our own Esri website used it for a landing page that is focused on COVID-19 resources. The story of the dashboard was featured on National Public Radio. It was in Science, Nature Index, the Wall Street Journal, and many other publications. Actually, I was even invited to talk about the dashboard and mapping of coronavirus on CNBC News. The dashboard went viral very quickly. Now, this graphic is showing you the first 3 months of feature requests starting from the dashboard's introduction. So I just want you to take a really close look at that scale on the vertical axis. Each division you're seeing is actually 500 million feature requests. And at its peak in late March, the dashboard was being requested 4.5 billion times per day. Now, compare that to the current world population, and you'll get a sense of how remarkable these numbers are. Compare that to two of the most viral applications in the world, Facebook with 2.7 billion users per month, and YouTube with 2 billion active users also per month. So I think you get the idea. The world took notice of the Johns Hopkins dashboard. Beyond alerting the world to the developing crisis, the JHU dashboard really inspired others around the globe to configure their own dashboards to map and monitor disease, like this one built by the Africa CDC, showing the COVID-19 status for an entire continent with options to focus in on various regions across Africa. In South America, we can look at the country scale and see that Colombia is paying close attention to the origin and importation of cases in their country. In Australia, for the state of New South Wales, the University of Sydney took their analysis all the way down to the postal code. In Asia, Hong Kong is sharing, of course, their cases and hospitalizations, and they're also mapping the actual buildings where there have been confirmed cases. Here in North America, the state of Maryland, for example, shares data at the zip code level, along with detailed information on testing volume and the percent of positive tests. Now, as a leader in transparency, this state is also sharing this dashboard, indicating ventilator trends and availability, as well as this remarkable dashboard that gives us statistical information for each and every nursing home. So you can see across every continent and at every scale, even all the way to the region of Timbuktu in Mali, people have been using dashboards to understand the novel coronavirus. People learned a lot from dashboards, and the experience of using geospatial information inspired them to see things differently, and the innovation around COVID-19 evolved. With COVID-19, governments wanted to start understanding gaps in service or health outcomes by figuring out who is more or less likely to be affected. Now, those that are more likely to be affected are considered vulnerable populations, and with COVID-19, people may be considered vulnerable for a number of different reasons, and we can visualize and analyze those reasons. Now, it could be older age or medical comorbidities that make some people more susceptible to severe disease. People may be vulnerable because they're essential workers and they're more likely to be exposed to the virus. Or perhaps the vulnerability is because they live in congregate housing situations like nursing homes, university dormitories, or prisons. We can overlay those various vulnerabilities and find the highest risk places for COVID-19. We also used analysis to perform capacity forecasting. Now, this is where we used a model that could take hospital bed utilization data along with social distancing behaviors and understand what might happen over time with local hospital bed capacity. I mean, every hospital and every government wanted to be able to predict whether their curve would stay flat, maintaining that health system's ability to care for each and every person who walks through the doors, or if some hospitals may become overwhelmed and exceed their capacity to provide care. Now, it turns out that two staples of geographic problem solving are site selection and calculating the geographic accessibility for places. Now, these methods have been used for things like standing up new testing sites, distributing food resources, and extending healthcare services in places where hospital capacity actually does become overwhelmed. Now, to do this, you use a process called location allocation. Let's just say that we want to stand up new testing centers. We'd begin to do that by determining the population demand, or you might think population need for that service. And we can overlay a bunch of factors contributing to each of the 5 COVID risk types. I mentioned some of these: transmission risk, socioeconomic risk, susceptibility to the disease risk, exposure risk, and resource insufficiency risk. In the end, these create a risk ranking over small geographies like neighborhoods, for example. And then you take those risk rankings and put them into your calculation, along with using road network data so you can calculate drive times and drive distances. And then you input any other kinds of constraints you might have, like maybe you only have a budget for 10 new testing sites, or you have only a certain number of staff that can support the new sites. The model takes all of that into consideration, and it selects the most optimal sites from your entire population of candidate options available. So the next thing you want to be able to do is help people find the resources that they need. Well, they use things called resource locators to do that, like this one that comes from Valencia, Spain. When placing a pin on the map, your current location, for example, the user can get information about the nearest hospital, pharmacy, social services, or testing sites in the area. You know, there's no question that COVID-19 inspired great innovation in connecting the dots to support the response to this pandemic. And the state of California actually has one of these resource locators for testing sites on their website that we built for them. As we saw the world move from strict quarantines toward staged reopening efforts, we knew that it would be important to map and understand trends. So my colleague at Esri, Charlie Fry, created this map that showed county-level trends in the US according to the 5 pandemic phases that are outlined by the World Health Organization. Now, pink colors indicate rising case numbers. Darker pink is the worst in terms of the number of cases per population. And I can tell you that most of the US is in dark pink. And actually, LA County is still in epidemic trend. But there's another interesting way that we can look at the very same data. Now, this one has arrows that tell you the direction that things are going. Purple is a worsening direction and yellow is an improving direction. And the steepness and the darkness of the arrow tell you how strong that trend is. Now, in this case, even though LA County is still in epidemic trend, which we take seriously, in general, it's been improving mildly. Now, another very interesting innovation with COVID-19 and geography is the ability to use anonymized and aggregated cell phone data to learn more about human movement. This company that created this map called Unicast provides grades for each county based on their social distancing behaviors. Now, in this regard, I'm sorry to say that LA County received a grade of F. Now, another data aggregator, SafeGraph, looks also at cell phone data at the block group level, much smaller, so you can really see patterns related to the percentage of time that people are spending at home on average compared to pre-COVID days. Now, this kind of information can really give decision makers insight about what's working, what's not working, where they may need to pay special attention and perhaps adjust their guidance. SafeGraph even shows weekly visitation data for specific places in a community. So, for example, around Emanate Health Queen of the Valley Medical Center, some of the most visited places are Home Depot and Chick-fil-A. Now, here's an application that has several innovations combined. I really like this one. So this is California by county, and we're starting with that Unicast social distancing grades, where a red grade means F and a blue grade is an A. So the first thing that we want to look at is the date that the California stay-at-home order went into effect on March 19th. And we can see below that there was no social distancing, so it was all red. But then we note that California coastal counties did a little better on their social distancing than the inland counties. So that's kind of interesting. But then something else happened in toward the end of April. On April 25th, we started to notice crowds congregating at the beaches. So you want to understand human behavior and what's happening. So we can add additional information here. And we're going to pull in a data set from NOAA with temperature information. Then we can make that information three-dimensional using what we call voxels. That's like a pixel plus volume is a voxel. So the darker brown, orange kind of colors are warmer temperatures, and the bluer areas are cooler temperatures. So now we can go through and compare social distancing to temperature very clearly. Now, Esri headquarters is located in San Bernardino County. We're going to focus in on that next. And you see a very clear correlation. When the weather gets warmer, we saw less social distancing. And I hope that it wasn't my fellow Esri employees that went to the beach, but you never know. Now, a lot of people are certainly wondering, what does the future hold? Well, the first thing I'll mention is a vaccine for this virus. The trick is, how can we distribute a vaccine to all of the people of this country and in the world in a way that's equitable and ends the pandemic as quickly as possible? There are some very complex and challenging issues in this effort that actually GIS can nicely support, like identifying facilities that can store and administer the vaccines, determining where concentrations of high priority populations are, exposing those gaps in access to vaccine and formulating plans to reach everybody. GIS can help manage and monitor the vaccine administration and inventory system, as well as share progress on vaccine delivery across our communities. So one of the key tasks for health departments will be to figure out how do we prioritize vaccine delivery, again, in a way that ends the pandemic as quickly as possible. This means considering vaccinating healthcare workers on the front lines first, then prioritizing other populations in consideration of those things we talked about, those most likely to suffer severe disease, like older adults, those most exposed, like essential workers, and those most likely to transmit disease, like people living in congregate housing. GIS can make this task a lot easier. Now, once you know where those critical populations are, and perhaps you've done some location allocation to find the best vaccine venues to administer the vaccine, well, then you can calculate the reach of all of those places. How many of the critical population can be served by each of those locations? It's inevitable that there's going to be gaps. Some populations will be out of reach of the vaccine venues. So we can make plans to site new vaccine venues like drive-through clinics and see how well we can serve the underserved population. We can also partner with locations that already exist, like retail pharmacies who may be able to support broader distribution for difficult to reach populations. As this enormous global challenge continues to evolve, it'll be important for decision makers to constantly evaluate this process and the productivity of each of the vaccination venues. And I think it's going to be equally important to share vaccine progress with the public. And actually, speaking of vaccines, I do want to take this opportunity to remind you to get your flu shot if you haven't already. It's never been more important than it is this year. And speaking of shots, childhood immunizations are decreasing during the pandemic. And this is just one of several health issues that are worsening due to COVID-19. I call them COVID orphans. People are delaying their health needs like cancer screening and chronic disease management. They're suffering from mental health burdens related to the pandemic, which are leading to increased substance misuse like opioids and increased depression. Now, it's really easy to see how this can happen when our attention is focused in just one direction, but the results of this could be dire. So let's put a stop to the COVID orphans and come back to care and keep up with your family's health maintenance. Health delivery is changing too this year. We're seeing a lot of healthcare ramping up on their telehealth and e-health options that they want to deliver. And you might wonder, well, how can geography help innovate in this area? Well, one of the first things that you can learn from geography is where there's need for additional health services. You can use maps to look at local household incomes, like this map in the San Gabriel Valley. We can also add to this information with things like unemployment rates or higher rates of disease to find pockets of greatest need if you wanted to set up, say, a new telehealth service, for example. Then you might want to be sure that the areas of greatest need actually have the broadband available to support telehealth services, like those areas in green. And then you could get really specific about what kinds of services are needed in different places. This map is just showing the locations of various types of disabilities in the community, because obviously the types of services that you offer vary if you're working with a community that has a high prevalence of cognitive difficulties versus mobility problems. We can also bring GIS indoors. In this case, it's more about relative spaces than geography, but the principles actually still work. Right now, a lot of organizations like hospitals are paying close attention to indoor space planning in order to bring people safely back into those kinds of buildings. Indoor GIS is being used to analyze seating arrangements and spot areas where we don't have at least 6 feet of physical distance, like the areas on this graphic shown in red. Once you know this, you can be really efficient in making proper adjustments. So this crisis, of course, is challenging. It's long-term, and it's not nearly over yet. So it's up to all of us to try to keep our public health concerns in balance with economic concerns. And I know that we're never going to forget our stories of isolation and quarantine, of local social distancing efforts, the hunt for toilet paper, and the creative ways that we wear face masks in public. And of course, my hope is that we never forget the valuable lessons that we've learned along the way. And like I said in the beginning, it is not uncommon to see innovation alongside a crisis. And actually, it's never really been enough to simply collect the dots, to collect the data. We need innovations like GIS to support health by helping us connect the dots in ways that inform and inspire and initiate changes that make us all healthier. And I will turn it back over to you, Dr. Calcat.
Thank you, Dr. Geraghty. It's just fascinating. It's amazing how technology can bring us together and help us move for next year or even next 2 years to fight this pandemic. We have a few questions. First of all, this may be proprietary, but a question asks, how does Esri collect all this information? What are the aggregators? If you can tell us how it is done. We know cell phone data, but what does Esri go after to get this data?
Yeah, so I would call it sort of an ecosystem and a community. We all work together. So Esri does collect a number of data points ourselves. We collect demographic data and spending and behavior data, 15,000 data variables in all. But for things like the social distancing data, we partner with organizations that do that, and then we help them get their data on a map that other people can use and as a service and pull into their applications. So we're very good at partnering, and during this pandemic, we've seen a lot of organizations volunteer their information. So it comes from multiple sources, but we can only take credit for 15,000 of those variables, and then there's over 100,000 different data sets that others have contributed.
Next one is, does Esri advise institutions, or does it send out alerts, or is it, can you buy this information from Esri to prepare, if I'm an institution worried about what's happening in the next couple of months in my area, and to prepare better? Could you comment on that, please?
Yeah, so that's a really interesting question. I mean, Esri is a very unique organization, and I would say we have more PhDs. I'm the only MD, but per organization than most companies. Nevertheless, we hesitate to act as the experts in different lines of business, although we have expertise in some of those areas. So what we try to do is enable organizations to do more with their own data and their sort of show off their own expertise and their own knowledge. And that doesn't mean that in some cases we don't step in and provide the guidance. We actually have an entire consulting arm of Esri that helps to do some of this enablement work. But again, it's a little bit of a hybrid of what the question is asking.
And next one is, there are various agencies which model COVID-19. Does Esri do a modeling, or it just presents what data you get?
So, I'm sorry if you could ask that.
Is that, like, for example, folks in Washington, they model so many deaths will occur in the next 6 months. Does Esri do similar modeling, or just presents the actual numbers as they aggregate them?
Yeah, I guess I would say we probably provide the tools. So I'll give you an example. One of the models that I showed was modeling the hospital bed utilization data and the idea of flattening the curve. And that was, many organizations created models to do that. The CDC has a model, and the University of Pennsylvania created the CHIME model. Many people may have read about that. what we did was I say, spatialized them. So we took those models as they were, we brought them into our software. So our addition to that is bringing the spatial component, which had not been included. So I guess, we're adding to the collective intelligence, but we're not necessarily creating the models from the beginning. We love to take the great work of the experts and make that even more useful.
The last one is, it's personal. What has been the most striking thing about this pandemic for you with all this data in the last 9 months at a personal level?
Oh gosh. Well, I'll give you one good thing and one bad thing that's striking to me. I guess the bad thing that's been striking to me is with all of the amazing systems that we have in place, and we think of ourselves as being in this era of technology and digital transformation. I've seen a lot, I've been disappointed frequently by the lack of interoperability of our systems and the ability to feed up data sets to get a cogent national picture. So that's been a disappointment, and I think that this experience is, in the positive way, going to advance us to the next level, no question about that. What has been on the positive side the most striking is the people, right? It's the innovative ideas and people jumping in, and the volunteerism. Esri gave away over 5,000 software bundles with services attached to help any organization that said they needed it. And we're seeing new business partners and other business partners doing the same thing, throwing in what they've got. Let's just help solve this problem. And that's completely inspiring and makes me want to work every day.
Okay, all right. Well, thank you again for your time. And this is really going to help us for a long, long time. And we know you're pretty close to us in Redlands. We look forward to you for many more important things Esri is going to tell us through you. Thank you, Dr.
Thank you.
Next, the second speaker of the day. It gives me great pleasure to introduce a leader who has been leading the charge, taking care of COVID patients in our San Gabriel Valley. Rob Curry is the CEO of Emanate Health. Not only he's leading the charge, but also continue to coordinate care through our command center, helping us and the communities around us manage COVID. Rob's been here at Emanate Health for 12 years now, and we look forward to his talk about how we are going to manage the unprecedented challenges this virus has thrown at us. His talk is State of Emanate Health and Our Future with COVID Around Us. Welcome, Rob.
Thank you, Dr. Calcutt. It's a pleasure to share this information with our community colleagues and allies. You know, I loved the introduction from Dr. Geraghty when she cited the Harvard Business Review and said it might seem counterintuitive, but during a crisis, there is an opportunity, in fact, a mandate to innovate. It did unite us. We had no real information about what a novel coronavirus is. Novel means it's not been cited before, it's new, and people didn't know how to treat it. People didn't know what was going to be needed to take care of the patients. But we sure learned in our innovative stages, and we looked at the system differently. We said, well, where are we going to get the N95 masks that we need to protect our staff? Our job was to help them help the patients. So we did create an incident command center. We did look at the system much differently. We unfroze the organization. An example is we had very few ventilators, but when the pandemic started, we acquired 40 new ones. There was a true bias to act, and we did that on a daily basis, if not hourly. We educated our staff and our community. We used our experts in infectious disease and critical care and our ER specialists, and we learned what we needed to do to advance the treatment of and care for our patients. So what sorts of things did that involve? As we move on, we started stockpiling personal protective equipment. That's perhaps the most important thing, as these frontline people risk their lives on a day-to-day basis, taking care of these very, very complicated and sick patients. We constantly studied other sources, such as the CDC, as to what was the best way to learn from the Center for Disease Control on how to help our staff. We continued on our clinical protocols. We enhanced our cleaning protocols. The first day, we started to limit visitors to our facilities to stop the spread of this horrific disease. Pursuant to the Governor's Act, we postponed and eliminated all non-surgical non-emergency elective surgeries. We separated our COVID-19 patients before they even got into the building. We constructed our emergency tent. We separated our people to go get the first treatment and evaluation in the tent that we thought were suspected of COVID, keeping the rest of the emergency department free from the COVID disease exposure. And we admitted these patients into isolated units. That was one of the first planning activities we did to innovate. We said, where can we cohort? Where can we concentrate care for these patients so that they're not affecting or infecting other patients, to keep all patients and staff safe? One of the first problems that we had was that of acquiring, testing, treatment devices. We had two already in the system. One was called BioFire and one was called Cepheid. They are very, very good at using the technology for the SARS diseases, but we couldn't get reagents. Nationally and internationally, there was just this demand supply phenomenon where at most we could get in one day were 10 sets of reagents to test 10 people, when we probably had a demand for more like 70 or 80. So again, we innovated. We went out and bought two more platforms for laboratory testing. One was called the Abbott and one was a thermocycler. So at this time now, 7-8 months into the pandemic, we can take a test and within 1 to 2 hours have a result. I will tell you that in March and April, even into May, some tests were taking up to 10 to 12 days to hear the results. So how many COVID patients did we get and how did we track it? Back to the first presentation. Well, here's just the data from the 22nd of this month, a couple of days ago. We are down to only 37 patients in-house. We've had 180 deaths, as Dr. Calcutt reported. We tested over 26, almost 27,000 patients, and we had 3,397 hospitalized. Now, that's a lot of patients when you consider that each patient stayed about 11 to 12 days for their treatment. But we were tracking this daily. We were talking daily as an incident command center. And our numbers in March and April and May and June were more like in the 150 to 160 number of patients and another 40 or 50 waiting for results. So I'm so proud that our heroes in the front line kept our patients safe and that we were able to help them keep safe through the use of personal protective equipment, training how to don and doff this personal PEE, protecting our staff with other safety initiatives that I'm going to show towards the end of my time here, to make sure that, again, our heroes who don't wear the capes, but they certainly were wearing N95 masks, surgical scrubs, goggles and face shields, gowns, and much, much more to protect them. Now, their work was heroic and remains heroic. They received many thanks from our community colleagues. There were many times where there were parades of ambulances and EMS providers and fire companies and the police departments and the sheriff's departments. They literally came to the hospital and drove, as you see in some of these pictures, with sirens, lights, and just truly showing appreciation for what they were doing, our staff were doing to help the first responders and what actions they had to take. I also note that our communities were so helpful too in supporting us. We had over 400 individuals and businesses help us create a relief fund, donated a certain number of PPE equipment, such as the surgical masks, but they really helped us purchase these critically needed supplies. I would thank our community leaders who supported our initiatives. Seen here are mayors from various communities. We turn to see people from our county and even our state and our federal representatives in government. I was in frequent contact with them to make sure that we were communicating our needs and they were helping us identify resources to contact. What I think is the big conclusion here through all of this is we're adapting to a new normal. This pandemic has not only talked about the impact on our ability to treat patients in a healthy and safe manner, but it also made us innovate. Dr. Geraghty talked about telehealth. Well, quickly into our planning, we adopted telehealth so that virtually a patient could call or could be seen on a screen, talk to a physician or a PA, a physician assistant, a specialist, whatever he or she needed, because they did not want to come into the hospital, but they sure needed advice and they needed support. So our new normal is seeing a lot of change to get into virtual visits. We, I think, are going to be a leader as we adapt to this. We are encouraging patients, don't wait, at least call or at least try and make contact through our virtual health platform. Which brings me to this point in the new normal. People are delaying their health care. Seen in this chart are the number of people, the percentage, who have reasons where they just don't want to come in to our hospitals. First of all, they're worried about getting sick. They're worried about an exposure to COVID. 77% of our population in San Gabriel Valley is saying that is their reason for not wanting to come in and a reason for delaying care. 57% said they're scared to just go to the hospital. They just don't know what to expect. And I think some are confused because at first it seems that the national response and our local response and California's response was, you know, if you don't really need to be in the hospital, don't go. I think that has carried through. So you can see here in the next chart that there is a very likely possibility that 7 out of 10 would continue to delay non-emergency treatment. And this, I would tell you, which is scary, affects not only those diseases where you might be able to delay, an elective knee procedure, but I am also talking about really important needs such as cardiac care. Many patients that have heart disease simply do not show up. They don't want to be exposed, so they suffer at home. I think this is one of the worst public health outcomes of the COVID disease is that so many others that suffer from the likes of cardiac arrhythmias are not coming into our hospitals. Simply stated as well, stroke patients. Signs of stroke are very easy. It's the Be FAST acronym. If there's a change in someone's balance, if the eyes are focused or one is not moving and one is, that's a sign of a stroke. A facial droop, an arm drift, speech problems, and then the last part of the stroke diagnosis is time. Time is brain in stroke care, and as the brain suffers from its problems, then the body is going to suffer thereafter. So we are encouraging people to not delay care. We have this video to share, which tells people that we are open, we're safe, we're clean, and we're ready to take care of them in this COVID world that we are having as a new normal.
As COVID-19 spread during the past few months, you were told home is the safest place. While you were at home, we were here, caring for patients and working around the clock to make Emanate Health a place you feel safe coming back to for all your healthcare needs. Our top priority remains to provide quality healthcare services in a safe, compassionate environment to our communities in the San Gabriel Valley. So here are 3 things you need to know. We are open. We are safe. We are clean. We are now offering a full range of elective surgeries at our hospitals and facilities. We are also taking appointments at our outpatient services. For non-emergency health needs, our ER check-in tool is also available for patients visiting our emergency rooms. Please don't delay the care you need. Call your doctor to make sure this is the right time to schedule a procedure or appointment. If you don't have a physician, use our Find a Doctor tool on emanatehealth.org. Emanate Health goes to great lengths to protect every single patient and staff member. These safety protocols are in place across our healthcare system. Everyone who comes to Emanate Health is required to wear a mask and is temperature screened. All patients scheduled for an elective surgery are tested for COVID-19. For pregnant patients who have a scheduled induction or C-section at our freestanding Family Birth and Newborn Center, testing for COVID-19 is administered prior to their due date. Our waiting areas, including those in our emergency rooms, have seating placed 6 feet apart to enforce social distancing. All suspect coronavirus patients who come to the ER are placed in a separate area while they wait for further care. Our admitted COVID-19 patients are placed in isolation units on a different floor from everyone else. We are limiting guests from visiting our hospitals and limiting access to hospital entrances to keep everyone safe. We have implemented tough antivirus cleaning practices to protect the health and wellness of everyone. These cleaning protocols include disinfecting our hospital rooms with an electrostatic sprayer. The fine mist penetrates hard-to-reach places and kills viruses in 30 seconds. Using state-of-the-art air purifiers and moonbeam UV lights to neutralize pathogens like COVID-19 for high-risk patient rooms. Wiping down counters, handrails, doorknobs, and other high-touch surfaces multiple times a day with EPA-approved disinfecting wipes that kills viruses within a minute. Installing more hand sanitizer stations at points of entry to our facilities, and providing surgical masks for all patients and staff who need them. Safety is part of our mission at Emanate Health. We're doing whatever it takes to make sure you feel safe to get the care you need when you need it. Our doctors, nurses, and healthcare staff are here to provide emergency, primary, and specialty care for you, our communities in the San Gabriel Valley. Thank you for always trusting us with your care. Welcome back to Emanate Health.
doing a lot of innovative work to make sure that patients are kept safe, that employees are kept safe, that we're doing the best we can to have a very clean environment and zero harm throughout our institutions. Consumer expectation and patient experiences are tied to our values of compassion and excellence and respect. And we're being good stewards of our resources. It's not just the clinical competencies, though, that make us a successful provider for both COVID patients and other healthcare people who need interventions, but it's our humanistic behaviors, the staff who are working tirelessly to show their compassion, their care, their commitment. It's what we do as a large not-for-profit health system. The system was impacted negatively from a financial perspective by this COVID virus, but we are still financially strong and able to meet community needs. So what are we doing for future care in terms of meeting the needs of our community? Well, you probably know that Intercommunity Hospital is called a STEMI receiving center. It is designated by the emergency medical system to receive very severe heart attack patients, meaning the STEMI is an ST elevated myocardial infarction. These are patients that need quick interventions. And when I say quick, I'm talking about a timeline of about 20 minutes from the arrival of the patient to the hospital to the time that they are in either our surgical suite or in a cath lab to receive the necessary cardiac care. We are so advanced that we are also noted for having a TAVR, a trans-aortic valve replacement surgical suite. And that suite was now used for the first time this past week to do a transcarotid arterectomy. Very sophisticated surgeries. And speaking of sophistication, you can drive to the Queen of the campus and you'll see one of the best, highest level 3 NICU units, neonatal intensive care units, available in all of California, if not in the country. You can drive to our digital imaging centers and see the latest in CT and MR and other sorts of imaging that provide extremely important diagnostic capabilities. You can drive also in our communities to receive rehab care at our freestanding rehab centers. At Queen of the Valley, as of this past week, we are now recognized as a thrombectomy-capable stroke center, a comprehensive stroke center, if you will. This is a center where if you are suffering from a stroke, where the brain can be entered through either a neurosurgeon or through a neurointerventionalist, and a brain clot can be removed quickly, and the patient is restored to health and a healthy status immediately. It's incredible how sophisticated this work is as we become a comprehensive stroke center. We're also trying to make it easy for you to seek care in alternative sites. I've mentioned the virtual capabilities, but we're also constructing a new urgent care center. We have purchased the property, we have been to the city for approval, and you should see construction start in the very near future for about a 60,000 square foot urgent care center. Back to Queen of the Valley, again, we are adding extreme capabilities this next year. We are building a brand new emergency department, 60 beds in that facility. State of the art, it will have its own MR and its own CT scanners. On the top of the 60 bed ED will be a 24 bed intensive care unit, again, state of the art, and this project will begin at the beginning of next year. Also on the Queen campus, we are partnering with an academic hospital provider to provide the best subspecialists to staff our future cancer center, which is seen here. We are additionally building parking spaces next to it. You can see behind the cancer center building another parking structure, and seen from the angle of Sunset. This is what the building will look like. So in conclusion, folks, we have adapted. We have been innovative. We have learned how to treat patients with COVID disease, although a cure still does not exist. But I just conclude by saying, we are here to serve you. Our mission is to help people keep well in body, mind, and spirit by providing quality healthcare services in a safe and compassionate environment. Safety is at the forefront. Don't delay your care. Rely on us to be your provider of choice. So Dr. Calcutt, I thank you for the opportunity to share our new normal, our struggles from the beginning, but our learnings at the end of how we have really been on top of treating COVID patients, as well as keeping advanced in all of our other service lines that are so needed in the million people that we, or for the million people that we serve. So thank you.
Thank you, Rob. Thank you. So we get a great snapshot of what's happening in San Gabriel Valley healthcare delivery systems. So Rob's been leading the team. It's a team approach, but he leads the team in managing COVID now and the near future. A few questions, Rob. First one is, yes, it has thrown a lot of challenges. What was the biggest challenge you faced in handling COVID?
The biggest challenge I mentioned was getting people tested in a reasonable time frame so that we could start interventions and know the status, the health status of the individual. The government just was not able to provide enough testing reagents and such to do so in a timely manner. So we really, at the beginning, and you were part of it, Gurjeet, you know what it's like to wait 12 days with a patient in a room wondering if they have COVID. So from a humanistic perspective and just from a clinical perspective, I think that's probably the worst memory. We were able to get enough staff on the positive side. We did bring in about 115 what are called traveler nurses. These are people from other states to help us make sure that we had enough nursing care available. I think another negative I would add is that we probably didn't need to shut down everything as the governor proclaimed. I think it did scare people away and is still resulting in delay of care. So that's what comes top of mind as to the challenge.
Next question is related to what you mentioned about testing. Maybe I can take that one. The question is, how can we get the most accurate test? So I could answer this. We have 4 platforms. Right now we have a platform called Abbott Rapid ID, which gives us the results back in 15 minutes. In addition to that, we have another platform called Quidel Thermocycler, which can do 96 tests at one go. So, and these tests are 98% accurate. So we feel very comfortable with these state-of-the-art testing. The next question is, are you or were you overwhelmed by COVID patients in the last 9 months?
No, I think we just learned how to prepare on a daily basis, how to communicate on a daily basis, how to staff on a shift basis. I think we were never overwhelmed. At times, yes, the emergency departments were very, very much at capacity, but I don't think they were overwhelmed. I think we got our patients to where they needed to be, got them the staff to start their initial care, and I think we just did an admirable job as a health system. And that's not me. That's the staff, the caregivers that are are our heroes.
Yeah, I mean, we actually at lower census than usual, people are still afraid to get elective care. So
Right.
I would encourage the viewers, if they have any family, friends who need elective surgeries or care, we are open and we have enough space for them in a very, very safe environment. That's all I see, Rob. Thank you again for leading us through this pandemic.
Thanks, all of you. Thanks, Gurjeet.
You are.
We're powered by a deep, enduring passion for our communities, and we pride ourselves on pushing the boundaries of what is possible so those we serve can be the best version of themselves. We strive to have our positive energy empower every life we meet, ensuring it radiates from inside all of us out into our communities. When we inspire those around us, demonstrating we want the best for every individual, we prove we're more than a healthcare system. We're family. And as family, we're there for our people and our communities through it all. Some call us their catalyst for change, their source for soaring, their beacon for healthier lives. And our new name is a symbol of this positive energy, this source of light. We are Emanate Health.
Next, we have a speaker who's going to bring everything together clinically. We have Dr. Bassi with us. Dr. Bassi is an infectious disease specialist in our community. I've been here for about 28 years, if I remember correctly. He and a group of 6 physicians have led the charge on COVID, helping us through this COVID confusions, the therapeutic maze, and he continues to provide us valuable care to our patients. It gives me great pleasure to introduce Dr. Bassi, and his talk is COVID-19 Becoming a Healthy San Gabriel Valley Now and Beyond. Welcome, Dr. Bassi.
Well, thank you, Gurjeet, and thank you everybody for those excellent talks before that and the nice perspective that Mr. Curry provided. At this point, I'm going to talk about the disease itself. You know, we've talked about how it's affected us and how it's affected all the resources that we've had to put into this. I'm going to talk about COVID-19 and just give a basic clinical background into the disease, and I'd be happy to answer any questions after that. So when you talk about viral infections like this, if you remember, there was something called SARS in 2002. This was a bad viral infection that started in China as well. And then there's something called the Middle Eastern Respiratory Syndrome several years later, which is still around, believe it or not. SARS is gone. The original SARS is gone, but MERS is still around. And both these infections were caused by a group of viruses called the coronaviruses. Now, we call them coronaviruses because under the electron microscope, you can see actual radiating spikes like the rays of the sun, and that's why it's called coronavirus. Now, it turns out that even now, about 10 to 30% of upper respiratory tract infections in adults that we were seeing before the current outbreak were caused by coronaviruses. And of course, we've heard of Ebola virus, which was a deadly disease, but unfortunately, or fortunately, it did not spread like the current virus does. Zika, we've heard of Zika that came and went. We've heard of H1N1, which was a very severe influenza strain that affected us years ago. So these things keep coming. And I'm going to give you a very brief, this is not a microbiology lecture, but I'm just going to point out this purple spike that you see on the surface of the virus, all these purple spikes. These are called the spike glycoprotein, or the S glycoprotein. And this is what the virus uses to attach itself to the target receptor in the human body. So this is a critical aspect of this virus, and we'll talk about it a little bit as far as vaccines are concerned. Now, how did this come about? Where did this COVID-19 really originate, and why did it come about? Well, it turns out that there's something called wet markets. Wet markets are markets where there's close contact between animals and humans. And you can see in this picture, this is a typical wet market in China. So if you can imagine, if there's some viruses lurking inside these animals, they could easily be transmitted to human beings. And indeed, of the common existing coronaviruses, we think that there's one called OC43, it came from cattle. And another one went from bats to camels. This is way back in the 1800s. And more recently, the SARS, original SARS that we had, went from bats to something called civet cats. And the Middle Eastern respiratory syndrome virus went from bats to camels. So bats are reservoirs of a whole bunch of viruses. They carry Ebola, they carry rabies, they carry these coronaviruses. But since human beings don't directly come into contact with bats, the infection has to go from bats to a different animal and then on to human beings. So this particular infection that we're talking about is COVID-19. COVID-19, by the way, stands for Coronavirus Infectious Disease. So it's the name of the disease, and 19 stands for 2019 when it was first discovered. And SARS is the name of the virus itself. So SARS causes COVID-19, just to clarify the terms. So this infection, we believe, went from bats to these animals called the pangolins. The pangolins are spiny anteater animals that are found in China, rural China, and there is contact between human beings and these animals, and we think that's how it spread. If you look at the composition of this virus, it's very much like the original SARS. So it's a SARS-like virus, and it's called SARS-2. So that's the backstory on COVID-19. Now, how does it affect human beings? So you have to get exposed to this in some way, and we'll talk about the different ways you can get exposed. But once you get exposed, the S spike that I showed you will attach onto a receptor, a specific receptor called the ACE2 receptor, which stands for angiotensin converting enzyme 2. And this is present in different parts of the body. So typically the lungs, that's why it goes into the lungs. But you can also have nasal expression. So some patients will lose the sense of smell and taste because the virus is present in this part of the upper respiratory tract. It also goes from the upper airways to the lower airways frequently, but not always. You can also have problems in asthmatic patients and patients that smoke particularly, because that's where this virus affects the human body. Besides that, the GI tract, kidneys, and testicles can be affected. So how is this transmitted from person to person? The most common way, and the one we have to worry the most about, are these respiratory droplets. Respiratory droplets are droplets that occur when you're talking or laughing or coughing and someone is within a few feet of you. So these droplets don't travel typically more than 3 feet, and they say up to 6 feet at the most. And these are greater in size than 5 to 10 micrometers. It's about the size of a red blood cell or bigger. You also have aerosols. Aerosols are smaller droplets that can hang out in the air for a longer period of time, and potentially they can transmit infection further, although this is less common than the respiratory droplets. Body fluids is very important for nursing staff. You know, the nurses that help patients in hospitals, the body fluids, including stool, can contain this particular virus, and the nurses have to be very careful dealing with patients. Fomites are objects around you that can have the virus on them. So keyboards, doorknobs, other things that someone who was infected touched, and then you go and touch that and then touch your nose or mouth, potentially the fomites can cause spread. Now it turns out that fomites are not as important as we used to think. This is the big one, the respiratory droplets. So if you wear masks, if you're 6 feet apart, and if you're outdoors, it's reasonably safe to get together. So the other question people ask is, how contagious is this virus? And I'm not going to bore you with the mathematics of this, but there's a number we need to know. It's called the R naught, and it stands for the basic reproduction number, and I'll explain what that is. And there's something else we need to know. It's called the case fatality ratio. That means how many diagnosed cases ended up dying with this particular virus. And we need some perspective versus the flu. That's why I bring up these numbers. So I'm sure there are mathematicians in the audience today, and they can work on this formula if they need to. But for practical purposes, how contagious is this disease? So if you look at COVID-19, one patient here in black will transmit it to about 2 to 3.1 patients. So that's how much typically the virus can infect other people. Zika was 3 to 6.6 people, so it was more contagious. Measles is the most contagious virus that we know. One infection can affect 11 to 18 people who are not previously immune to it. And if you compare it to the flu typically goes from 1 person to 1.3 people. So if you compare the flu to this particular virus, the COVID, this is at least twice as more contagious than the flu. So how serious is this problem? You know, was it doomsday, the end of the world, like the I Am Legend movie? Or is it just another flu, like some people think, it's nothing, I'll get over it. So it turns out that, first of all, the R naught is higher than influenza. It's twice more contagious, but far less than measles. Measles is much, much more contagious than this disease. And also the case fatality ratio, you know, this is the total number of diagnosed cases versus how many died. So as of today, we have 230,000 deaths in the United States and something like 8.2 million cases that have been diagnosed. So if you look at that ratio, the ratio today is about 2.6% in the United States. But remember, this is only the people that were diagnosed. We also have, for every person that was diagnosed, there are people in the family that never got tested. So the actual number of cases is a lot more, which brings down the mortality rate. Now compare that to influenza, it's only 0.1%. So this is at least 10 to 15 times a higher fatality than the flu and twice as contagious than the flu. The other problem with this infection is asymptomatic transmission. You know, sometimes people will come to work or they'll be around their family and they have no symptoms. But for 2 days before the onset of symptoms, they can frequently start to infect other people. So that's called pre-symptomatic transmission. The other thing is there are people that keep shedding this virus. So they're discharged from the hospital, everything looks good, but their repeat tests keep coming up positive. And that doesn't necessarily mean they're still contagious. How do you diagnose someone with COVID-19? Typically, they'll have fever, they'll have a dry cough, they'll have body aches, headaches. They can also have GI symptoms like nausea and diarrhea, and they'll have loss of smell and taste that I mentioned earlier. Now, obviously, this is not an exhaustive list. People can develop symptoms of other types as well, but this is the more common ones. The one clinical clue is coryza. Coryza means a runny nose and runny eyes and sneezing. So if a person has runny nose, runny eyes, sneezing, it's probably not COVID. It's more like allergies or some other respiratory infection. The problem, of course, with COVID is it can progress to pneumonia. And this typically happens during the second week. So during the first week, people will have fevers, body aches, sore throat. And then if they're going to start to get better, they'll start to get better by the second week. If they're going to get worse, that's when they end up in the hospital. And usually, if you make it past 2 weeks, you tend to do better and recover. This is the particular blood test which tells us what the prognosis is. So let's say a person develops COVID. 81% of patients that develop COVID will have only mild to moderate disease. This includes mild pneumonia, by the way, like we think President Trump had. The next is severe disease, where you have greater than 50% of your lung involvement or you're short of breath. Hypoxia means you're short of breath. Dyspnea, short of breath. And critical disease occurs in 5% of patients, where you end up in the ICU, in shock, or in multi-organ failure. This is important for everybody listening today. If you have the COVID, how do you decide when to go to the hospital? Not everybody with COVID needs to go to the hospital. They only need to go if you become short of breath at rest. So, and you know, there's a device called a pulse ox that you can put on your finger, and it can give you a saturation. And if it's less than 93% and you're short of breath at rest, then you go to the hospital. Or if you're high risk, and I'll talk about high risk as well, but if you're elderly, which 60 plus, that makes me and Dr. Calcat and everybody else elderly. But for the purposes of this study, 60 plus was considered elderly. Or if you're obese with a BMI greater than 30, or if you have diabetes, particularly if it's uncontrolled, then, and you start to become short of breath, you need to go to the hospital. So of the patients that, and this is one particular study in the United States, they found that of all the patients, 19% got hospitalized, 6% went to the ICU. Overall case fatality ratio was 2.3%, which is kind of goes along with the current numbers of about 2.6%. But if you have critical disease, if you've ended up in the ICU, then your chances of passing on from the disease were 50%. It's almost a flip of the coin. There are risk factors for severe illness that we need to recognize. Age is the big one, like I mentioned. Less than 55 years, you tend to do well. 55 to 64 years, you can have problems. Greater than 85, there's a higher mortality, 10 to 27% mortality. So age is very important. When we say we want to protect our vulnerable, we want to protect older people in the population. Also, if someone has heart failure or a bunch of cardiac conditions that I mentioned here, but not high blood pressure by itself. So if you have high blood pressure, it's controlled, you're taking medicines, then it's not considered a higher risk factor. And it turns out that if you do have these risk factors, or what we call comorbidities, the mortality rate or the case fatality rate is much higher, independent of age. So when you compare two groups of the same age, if someone had diabetes or cardiovascular disease or chronic respiratory disease like COPD, their mortality tends to be a lot higher. And if you've had previous strokes and chronic kidney disease, so basically chronic health conditions, it's very important to be monitored by a physician, and if nothing else, through a telemedicine visit, just so they can keep an eye on things if a person has COVID before they decide whether to go to the hospital or not. Once a person gets better with this, and 97.5% of people will get better, the viral RNA shedding will decline as your symptoms go away. But it doesn't go away completely, so the shedding can continue for days to weeks. And this is an important concept, for everyone to understand. Let's say you're released from the hospital, you're feeling great, you're back up to speed, you want to go back to work, and your work requests a test. You do another test, and that comes back positive. Well, that does not mean you have viable infectious virus anymore. We call it COVID debris. It just means it's fragments of virus that are still present in your respiratory tract, which the PCR test, which is a very sensitive test, amplifies and calls it a positive test. Important to remember this. So for a rule of thumb, if someone had mild COVID, that means they were not hospitalized and did not need oxygen, After 10 days, you're no longer contagious. This is 10 days from onset of symptoms. If you had severe illness, such as ending up in hospitalization or on a ventilator, or you were very ill, then 20 days is the rule. So this is a good clinical rule of thumb that we follow and when to take someone off isolation for COVID. And also, once a person recovers from this, they do form some antibodies, because these are called IgG and IgM antibodies. These last for about 3 months for sure. So we think a person has immunity at least for 3 months after they become infected. We just don't know how long this lasts. And there have been some cases of reinfection that have been documented, but currently it's only a small handful. So the vast majority of people that get over this will not become reinfected, but it is possible to develop reinfection. So you don't have the so-called golden passport where you got sick and after that you can go anywhere and do whatever you want without protection, with masks, because reinfections do occur. Now, this is more for the nursing staff and other physicians that are on this call. The typical chest X-ray findings, we see pneumonia in both sides of the lungs, and it tends to be rounded as well as peripheral airspace. So it can be along the periphery of the lungs. But importantly, in early disease, the chest X-ray can be normal. So, you think you have COVID, you go get a chest X-ray, it's normal. That does not mean that you don't have COVID. It can still be there. The CAT scan is far more sensitive. So we have patients that come into the emergency room, we do a chest X-ray, that's normal. We do a CAT scan of the chest and we'll see this. We'll see peripheral infiltrates, which over time resolve. But again, a CAT scan is not recommended as a diagnosis methodology for COVID. So, as Dr. Calcat and Mr. Curry had mentioned, there were situations where we would not get the COVID test back for a week or 2 weeks in some patients, and we had to make a diagnosis. And we would do CAT scans and other things, and if we saw something like this, we would think this is likely to be COVID, but it's not 100%. So CAT scan is not the gold standard. This is important as far as treatment. How do we treat severe COVID? If it's mild COVID, you stay at home, you take care of your fever, you make sure you get plenty of fluids, you quarantine yourself for 10 days from onset of symptoms. And that's all you need. You monitor your oxygenation at home, you make sure you're not short of breath. And I gave you the situations when you go to the hospital. But in the hospital, we treat the pneumonias, we treat something called adult respiratory distress syndrome, we treat septic shock, cardiomyopathies, arrhythmias, kidney injury with dialysis, secondary infections, GI bleeding. So there's all kinds of complications in the severely ill patients that are in the ICU with COVID. And those patients still have a high mortality. One of the aspects of COVID is it causes clotting of blood vessels. So we always use blood thinners when patients come into the hospital. And this is part of the problem. If you get clots in your lungs, then you can't breathe. And that's why it makes breathing so much more difficult. You can also have large clots, what are called pulmonary emboli. Some patients see this. This is called COVID toes, where you get clotting of the blood vessels that supply the toes, and you get this. And some patients may have only COVID toes and not the rest of the disease. It's very strange. Others have rest of COVID-19 and this. So this is the microvascular thrombosis of the toes. We also see heart attacks in patients. We see strokes in patients, all because of the clotting that occurs. How do we treat this? There's a medicine called remdesivir. So I would, as a example, I would go over what happened to President Trump when he got ill. The first thing he got was some antibodies, monoclonal antibodies, which are not currently available for everybody, but we think will be in the next 4 to 6 weeks. And he's promised to make them free for everybody. What the monoclonal antibody does is it goes in and it neutralizes the virus. Now for us, we don't have monoclonal antibody, but we have something called convalescent plasma. This is the blood product from someone that has previously recovered from COVID. The Red Cross separates out the red blood cells. Whatever's left is called plasma. And then we take that and give it to patients that are ill. Secondly, the president got remdesivir. This is the medicine that actually targets the COVID virus or the SARS-2 virus. And it seemed to be very effective in his case. The key is to take it early. If we wait too long, 2 weeks before you come in, then it can be a problem. Then there are all these other drugs that were tried, and some of them help and some don't. One important concept is we don't like to give steroids early in disease. So if you're not hospitalized, you should not be on steroids because that can worsen infection. So this is what everybody wants. They're like, we're sick and tired of this. We want normal life. Please make it go away. Pretty please. So how do we do that? And this is key. The vaccines are going to be key. Once we get vaccines and we vaccinate the entire population,
Any question of why COVID tends to impact.
We can also work on masks and staying 6 feet away from people and washing our hands. Over time, we'll get herd immunity if enough people have vaccines. And we do think over the next 3-6 months, hopefully, this is going to be better. It might not completely go away, but we'll have a better handle on this. As we know, there are multiple vaccine trials going on, and we'll have some vaccines coming soon. And I'd be happy to answer any questions, but stop blaming the animals. Thank you.
Thanks, Sanjit. This was so informative. We have a few questions. Actually, you answered the first question a little bit. I have family members who still don't take this seriously and say that the case and the death numbers are bloated or inaccurate, or that we could just achieve herd immunity if we all just got around and went about doing our business while leaving the vulnerable ones at home. I don't know how to convince them otherwise. Any suggestions?
So the problem here is it's very contagious. So if you think you can save the vulnerable by completely isolating them, and it's the young people that are talking about this, maybe, but in reality, when people live together in a house and grandpa and grandma are living at home, and the grandchildren go out and pick up this disease, it can be a disaster for the older people. So the key still is, till we get vaccines, we have to keep the numbers down. We have to make sure hospitals don't get overwhelmed again. We have to make sure everyone wears a mask, everyone does social distancing, and everyone washes their hands frequently.
Yeah, if I may add, herd immunity works, but it'll take a long time, and in the process, we will kill a lot of vulnerable people in our population, the elderly or the folks who have immunocompromised.
Exactly. Herd immunity, if it's achieved through exposure of people to a deadly disease, you're going to end up with a lot of people dead. But
Yes.
if it's achieved through the vaccines, then it makes sense.
The second question is, typically how high does the fever go when you have COVID?
So this is interesting. A person can have high fevers, like 103, 104 degrees at home. But if they're not short of breath, then still don't need to come to the hospital. You can control your fever with cooling measures. You can use Tylenol, you can use Motrin, you can alternate that. But it's only the lungs. When the lungs become involved, then we're in trouble. That's when you end up in the hospital. So fevers can be either non-existent, so those are asymptomatic patients that can spread this, or they can be real high, up to 105 degrees. It depends on a person's immune system.
Thanks. Next question we have is, if convalescent plasma is given to a patient, can that patient get reinfected?
I'm sorry, if plasma is given to a patient, can the patient what?
Get reinfected. And
In relief. Yes.
the question is that you already have the antibodies from the plasma. What are the
Correct.
chances of reinfection?
Oh, can they get reinfected? Yes, I mean, you can get reinfected even with native infection, so even without plasma. And certainly with plasma, what can happen is if the plasma is given early and it kills off all the virus and your own body doesn't have time to make antibodies against it, then you can get reinfected. Yes, that's a good point.
Next question we have is, for mild to moderate symptoms not requiring hospitalization, do you recommend taking aspirin to avoid clotting or thrombosis?
You know, this is a recent study that I saw where they suggested it's beneficial. Now, you know, there are further studies going on and the answer is not completely clear. There are downsides to aspirin. And if someone has a pre-existing ulcer, for example, they can start to bleed. But there is some evidence now that if you do take some aspirin, low dose aspirin, just enough to suppress clotting, it may be helpful in mild disease. That's early.
Especially if you just take it for a week or two during the course of the disease. Yeah.
And the other things that help, Gurjeet, is vitamin D is supposed to be helpful, and zinc supplements is supposed to be helpful.
Yeah.
So these are, again, soft, you know, data. These are not randomized, double-blind, placebo-controlled studies, but there is evidence that high vitamin D levels may be protective against COVID.
Actually, that study came out which showed that folks who came in with normal vitamin D levels during their hospitals did better than the folks who had low levels. So vitamin D levels in the right range.
But the problem with that study, of course, was you don't know if it's a cause or an effect.
Yeah.
You know, if someone is really healthy, they're outdoors all the time, they're exercising, they may have good vitamin D levels, and maybe that's why they fought this off better. And the vitamin D was just a marker of generally good health. So we don't know if it's a cause and not an effect, but you're right. There was an association between good vitamin D levels and mortality.
Another question, if one is exposed to the virus, are you immediately contagious? How long does it take before one becomes contagious? Basically talking about the incubation period.
Incubation period is up to 2 weeks. So if I get exposed to somebody today, you know, for the next 2 weeks, I could be harboring this virus and that it could become active. So at the end of 2 weeks, if I'm still fine, then I dodge that bullet. But it can be up to 2 weeks.
All right. Next question is actually about vaccine availability in San Gabriel Valley. I can take that. So about 3 weeks ago, we were notified by the California Department of Public Health that we will be getting 2 vaccines for our employees and the medical staff. As you may know, there are 4 front runners in the vaccine race. We have the one from Oxford, so-called the AstraZeneca vaccine. We have one from Pfizer, which is collaborating with a German firm called BioNTech. The third one is the Moderna, which is collaborating with the NIH. And lastly is the Johnson & Johnson vaccine. So we are most likely going to get at Emanate Health somewhere in November or December, the Pfizer vaccine. We would be having enough dosages initially for our frontline workers, but they have asked us whether we will be helping the Department of Public Health distribute the vaccine to the EMTs in the area and the vulnerable population. So stay tuned to Emanate Health site, and we will be messaging it to you if we get the vaccine, whether we'll have a vaccine which we can give it to our surrounding communities, especially the vulnerable population. That means the elderly and the folks in the nursing home. Next question we have is, could you please comment on, quote, long haulers? These are folks who have symptoms of COVID-19 many weeks after they've quote unquote, sort of recovered from the acute hospitalization.
Yeah, Gurjeet, it is, you know, it's a new virus. So we're learning about it, we're collecting data, and there is no question. There are some people that have chronic chronic leftover symptoms related to this. So you can have pulmonary symptoms of fibrosis in your lungs, or you can have chronic fatigue or fibromyalgia, or those type of conditions. However, because it's a new virus, some people may get over this in 2 months, some may take 6 months. So they might not really be that long of a long hauler. And, you know, we'll have a lot more information in about a year from now as we follow patients that have had this to see how they recovered from this. And the other point I'd like to make is, while, you know, we read about the numbers of COVID and all these cases that are occurring every day, we have learned how to deal with this as time has gone on. And I would like to reiterate what Mr. Curry said as far as there are other situations that occur. If someone gets chest pain from a heart attack, it's more dangerous for them to stay at home being worried about COVID than, you know, coming to the hospital and having that taken care of. The same thing applies to cancer patients. You know, the people that have lumps that need to be biopsied, people that need to be started on chemotherapy, they're people. So one cannot and should not delay care, health care in this situation. We're just going to have to adapt, and there will be a new normal. And once the vaccines come out, I think it'll be a lot less of a concern for everybody. But even now, the way we handle this in the hospital, our frontline workers, our doctors, our nurses, our therapists, they've established a safe environment, and it is appropriate for people to seek and get the health care that they need.
Thanks. A little more on the long haulers. There was a question: how is Emanate prepared to help the long haulers? From that perspective, yes, as Dr. Baxi mentioned, they have brain fog, they have fatigue, and some of the folks who have recovered from the main target organ, which is the lungs, do require oxygen therapy, and some develop scarring of their lungs. We do have a rehab program which will help these individuals, just like we do for our patients with emphysema. Next, we have another question. How long do the droplets remain suspended in the air if somebody has COVID and coughs?
So if it's respiratory droplets, they don't stay there very long at all. I mean, typically they fall to the ground, and it's less of a concern. It's only if you're in someone's face when they're coughing in your face and both of you are not wearing masks that it becomes an issue. The aerosols are different. The aerosols are much smaller droplets which can remain airbound, and they can be present for hours, sometimes 3-4 hours. But again, if the ventilation in the room is good, or if you're outdoors, it's not a concern, because the ventilation dilutes out what we call the inoculum, or the amount of infectious virus, and it's not as much of a concern. However, if you're in a room without adequate ventilation, you're indoors, and this is more important now in the northern part of the country where it's cold and people do tend to be inside. Often because of the heat, the mucous membranes are dry, their resistance to infection is lower. That's the time when aerosols can be a problem. Also, along the same lines, I'd like to reiterate the importance of the flu shot. Everyone needs to get a flu shot, because you don't want to first get the flu, become real weak, and then get the COVID, which can be very dangerous.
Thanks. How safe would you say that gyms are if one has to go to a gym?
Gyms are still not, in my opinion, they're still not where they need to be. You know, if we have a rapid test that we can do in patients before they go into the gym each time, if it's adequately ventilated, if it's an open air sort of a situation, if there's plenty of distance, maybe, but most gyms are not there as yet.
Yeah, I think, add any area which is enclosed, it's still not safe. So whether it's gyms or airplanes, we do not recommend going to those areas unless we really, really need to do those things. We have another question. If I am not symptomatic, do I need to be tested for COVID-19? I think the question comes to more for like epidemiology perspective. So, do you want to answer that?
So if you're not symptomatic, it depends on your exposure. You know, if you're not symptomatic and you've not been exposed for sure, it makes no sense to get yourself tested. If you're not symptomatic, but you got significant exposure, there's someone in the household that was diagnosed with COVID, then you should be tested just to see what your current status is, because there is asymptomatic COVID. You know, you can have the COVID and not even know it. So it depends on your exposures.
The question, I think you answered that. Are patients sent home that are still positive? And you answered that you can still be positive on the test because those are remnants of the virus, but that doesn't mean they're contagious after 3 weeks of being sick. A prescriber ordered me azithromycin for COVID. Is it still being recommended?
So COVID is a viral infection, and as such, there is no effect of antibiotics with the COVID. The problem is, though, sometimes someone will come into the hospital very sick, and we don't know if it's COVID or is it a bacterial pneumonia right away. So initially, we will cover the patient with antibiotics as well. And then if it turns out that this is COVID and there's no evidence of bacterial infection on the blood tests, then we usually stop the antibiotics. And I think on an outpatient basis, it's the same situation because you still can get bacterial pneumonias. And if someone goes into a physician's office and they're very ill, it's often, you know, the Zithromax is prescribed to cover for secondary superimposed bacterial pneumonias. But by itself, it does nothing for the COVID.
This last question we have is, what is the expected immunity from the vaccine? How long will it last?
Well, only time will tell. But the theory here is the antibody titers that you get in your blood from the vaccine, and typically you'll get a second dose, a booster dose a month later. Those antibody titers are so high that we expect at least about a year's worth of protection. And it may be that at the end of the year, if COVID is still around, we might need another booster. But the levels of antibody are way higher than what we get with normal natural infection. In that case, usually it lasts for about 3 months. With the vaccine, we think it could last for about a year or more. We'll see. Only time will tell.
Yeah, if I may add, I mean, some of these vaccines are going to be about 50 to 70% effective. If we feel that if one gets the vaccine and they get an infection, it won't be that severe. So clearly it's going to be very, very protective. So we do recommend as physicians getting the vaccine. We think the vaccines are safe. They have been tried on 30,000 volunteers, the phase 3 trials, and the vaccine manufacturers are quite careful to pick up any side effects and stop the trials. So we definitely really want you to take the vaccine and if it comes out. Of course, we don't know which one is the best for presently. Only time will tell, but we do recommend that you should take vaccines.
What I have to say about that is when the vaccine's out there, I'll be first in line to get it.
That's so good for you to say that, and same is true for me also, absolutely. That's all the questions for Dr. Bassi. There is a question about visitation hours. Right now, Emanate allows visitors to be there for half an hour every day. We do follow the local department health guidelines right now. That is acceptable to them. Once the numbers get even better in our area, we will increase the visitation hours. If we understand and realize that it's very important for a patient who's hospitalized to have visitors, but we want to protect everybody. So keeping that in mind, we are limiting them to half an hour. There is one more question which popped up. What ages can get the vaccine? Right now, there is no guidance on that. We know that kids don't get this disease that severe. You know, below 2 years, it's practically kids don't get. any serious complications from this virus. We do have a syndrome called multi-system inflammatory syndrome in children, so-called MISC, where the kids get this virus and about a month later have rash, have swollen feet, develop inflammation of their blood vessels, affects their heart. Unfortunately, the numbers are very, very low, but that does happen. So we do not have any guidance who will be eligible for this vaccine from CDPH or NIH. We will be messaging that as we know more about this vaccine.
Also, initially, it's a supply concern. You know, they can make 100 million doses, and it has to go to the first responders, the hospital workers, the prisoners, there are high-risk groups, and of course, elderly people, nursing home patients. It'll be prioritized towards those first. Absolutely. And later, if it's safe for kids, it'll be extended to children.
Okay. That's all the questions, Sanjit, I have for you. Very much appreciate your time. This conference is being recorded. All the participants can have the link and they can forward the link to their friends and family if they want to. We do have raffle winners in this conference, and they will be announced via email following this event. So this is where we are with COVID today. This is the current status, but we know it's evolving. We know this virus has thrown so many curveballs, and we have to pivot very, very quickly. We want you to feel comfortable that Emanate will be your go-to place to learn more about this so that you're prepared for this virus in the near future. We want to thank our sponsors, and I want to take this opportunity to thank the speakers, Dr. Geraghty, Rob Curry, Dr. Bassi, for sparing their time on a Saturday and really enlightening us about this deadly disease, which is so unprecedented, and we have to take all what we can from them to live better or live safely so that we can survive this pandemic. And thank you to the audience who have tuned in. I really appreciate your time too. We want you to stay safe. We want you to stay informed, and as they say, mask on. Thank you so much. And this ends the conference. Thank you.